Welcome to the Deep Dive. We're your shortcut to getting seriously well informed. Today, we are undertaking a pretty complex mission. It's a deep dive into the clinical view of atypical sexual interests. Where they come from, how they're classified. This stuff sits right at that intersection of neuroscience, psychology, and, well, social dynamics too. It forces a really specific clinical look at human behavior.
And that clinical lens is absolutely necessary. Our sources are really focused on one core question. When exactly does an intense, persistent, atypical sexual interest, what the clinical world calls a paraphilia, cross that line? When does it become a paraphilic disorder? We really have to separate the desire itself from the diagnosed condition.
That distinction, that seems absolutely fundamental here. The diagnostic manual, the DSM-5-TR, is apparently incredibly clear about this. Just having the atypical sexual interest, the paraphilia, that's not the disorder in itself.
Exactly right. The key takeaway right up front has to be that the pathology, the disorder part, it's defined entirely by the consequences of that desire. We only start talking about a disorder if pursuing that interest causes, significant distress, major problems in the person's life, or, and this is critical harm or the risk of harm to other people. It's all about the functional impact. That's what determines the diagnosis.
Okay, so let's start there. What do the clinical sources actually mean by a paraphilia? You mentioned the term. Formally, it's described as any intense and persistent sexual interest other than sexual interest in genital stimulation with phenotypically normal, physically mature, consenting human partners. That's quite specific.
It is specific, and what's important about framing it that way is it immediately highlights, well, the huge spectrum of human sexuality. What counts as abnormal can be very culturally dependent, can't it? But this clinical definition, it tries to provide objective, sort of functional boundaries. Most atypical interests are just unusual, maybe inconvenient for the person, but essentially harmless.
Right. And that leads directly into the two ways an unusual interest gets elevated to a full-blown paraphilic disorder.
The first pathway is more subjective. It focuses on the individual's own distress or impairment. This happens when the person feels intense anxiety or shame or guilt about their interest, or if the desire becomes so consuming it actually interferes with major life functions. Think job loss, serious debt, maybe a marriage breaking down because of it.
That makes intuitive sense. It's sort of like the difference between, say, someone who really loves collecting rare books and someone whose collecting habit bankrupts them. It's the functional impairment, the negative consequence, that signals the pathology, not just the interest itself.
Exactly. Couldn't have put it better. The second pathway, though, is objective. It's absolute. If satisfying the desire inherently involves someone who hasn't consented or can't consent, it's automatically defined as a disorder. Full stop. This includes things like pedophilia, obviously voyeurism, exhibitionism, frauderism. The harm is kind of baked into the act.
Okay. And what about things like fetishism, where the focus is on, say, objects or specific non-genital body parts?
Good question. In those cases, the diagnosis hinges entirely on that first criterion, the distress and impairment to the individual. And this is where the line is really important. Things like consensual BDSM practices between adults. They are specifically not classified as disorders unless they cause that significant distress or impairment. Consent and the absence of harm are the key clinical differentiators there.
Okay, this framework is becoming clear. So given this clinical reality, the huge question then becomes, why? Why do these intense, atypical interests develop? You mentioned we're not looking for one single answer, but more how the sources weave together this biopsychosocial model.
That's right. It's multifactorial. We really have to start with the biological and neurodevelopmental factors. It's foundational. Our sources point to a growing amount of neuroimaging evidence. It suggests there are actual structural and functional differences in the brains of individuals with certain paraphilias.
Differences where? What parts of the brain are we talking about?
Well, the main findings seem to involve the frontal cortex. That's our brain's CEO, basically. Handles impulse control, judgment, executive function. Studies suggest there might be reduced volume or maybe weaker connections there. And if your frontal cortex isn't working optimally, well, it's harder for the brain to put the brakes on an intense urge, even if you know the consequences are bad.
So the stop signal mechanism might be biologically weaker, in a sense.
That's a good way to think about it, yes. We also see findings related to the temporal lobe. That area processes sexual stimuli and social cues. So problems there could lead to disinhibition or maybe misinterpreting social signals, figuring out what's an appropriate target or interaction. And then there's the brain chemistry side, neurotransmitters.
Like serotonin. We hear about that a lot with impulse control issues.
Exactly. Lower levels of serotonin are pretty consistently linked with general impulsivity and poor behavioral control. So imagine someone has a biological predisposition towards an atypical arousal pattern, and they have a brain chemistry that makes it harder to resist impulses. That creates a significant vulnerability. The urges just become much harder to manage.
And even before birth, you mentioned the sources touch on potential prenatal influences, this neurohormonal theory.
Right, it's complex, still being researched, but it's a compelling idea. It basically suggests that atypical levels of exposure to sex hormones, particularly androgens, during critical periods in pregnancy, maybe the second or third trimester, might actually alter how the brain develops in ways related to sexual preference and interest. Now, these biological factors, they aren't destiny, they don't guarantee anything, but they might lay down a certain predisposition. They kind of set the stage upon which experience then plays out.
Okay, so if biology sets the stage, how does psychology write the script, so to speak? Moving into those developmental experiences, it sounds like classical conditioning is seen as a key psychological mechanism for how a specific atypical interest gets locked in.
That's the learning component, yes. During those really formative stages of psychosexual development, which are quite vulnerable periods, if an intense sexual arousal, maybe even a traumatic one, gets repeatedly paired with something initially neutral, like an object, a specific situation, a non-genital focus, that neutral thing can become permanently fused, neurologically speaking, with the sexual response. That's how something non-sexual can end up having immense sexual power for someone, sometimes lasting a lifetime.
The sources also seem to emphasize a darker side of development, a strong link between early life trauma, particularly childhood sexual abuse, and developing paraphilic disorders. That kind of trauma must create really distorted ideas or schemas about intimacy, power, connection.
Absolutely.
Right.
And critically, especially in paraphilias that involve harming others, these individuals often develop these deeply ingrained cognitive distortions. These are basically systematic errors in thinking. They function like self-justification mechanisms, allowing the person to kind of neutralize their own guilt and continue the behavior.
Can you give an example? How does that distortion process actually work?
Sure. Someone engaging in harmful or illegal paraphilic behavior might use rationalizations like blaming the victim, they were asking for it, or minimizing the impact, no real harm was done. A really disturbing distortion the sources mention is kind of dehumanizing the victim, or, as we touched on, this twisted belief that a non-consenting person, especially a child, is actually a willing participant who somehow benefits. Challenging these thinking errors is absolutely central to therapy because if you don't dismantle the distortion, stopping the behavior is almost impossible.
Okay, so we have biology, conditioning, trauma. What about the social world? How does that factor in?
The social context often acts like an accelerant, you could say. Sources frequently mention things like chronic social isolation, intense loneliness, maybe poor social skills in individuals who develop these disorders. For many of them, forming healthy, complex, trusting relationships with consenting partners just feels too difficult or too risky or maybe just too overwhelming.
So the fantasy world, the paraphilic fantasy, becomes a kind of substitute.
Oh,
Because it's predictable, controllable, unlike messy real-life relationships.
exactly. It's often a maladaptive coping mechanism. The fantasy offers immediate, reliable gratification and a sense of control. It can serve as a substitute for both intimacy and sexual release, which then reinforces the whole cycle and can push the person even further into isolation.
Which brings us right back to that tricky ethical and diagnostic line we started with. If the causes are this tangled part brain chemistry, part learned associations, part trauma response, how does the clinical world draw that firm line, distinguishing an unusual but harmless fetish from a disorder needing intervention?
It really comes down entirely to that functional status assessment. Let's take that fetish example again. If someone's interest, say, in a specific material leads them into severe debt buying it, or they get so preoccupied they can't hold down a job, well, that's clear functional impairment. It meets the criteria for a disorder because of the suffering and dysfunction it's causing that individual.
Okay. And contrast that sharply with consensual activities. If two consenting adults engage in something atypical, maybe very specific, but it causes them no personal distress, doesn't mess up their lives, involves no harm, then it simply doesn't meet the criteria for pathology, right? The DSM is clear. Pathology is the distress or harm, not the desire itself.
Precisely. The desire isn't the target, the negative consequences are. And that leads us straight into treatment because when you're treating something rooted in potentially neurobiology and definitely in deeply learned psychological patterns, The goals have to be pragmatic. It's rarely about curing or completely extinguishing the desire. That might not even be possible. It's about management, control, and stopping harmful behavior.
Right? Boosting self-control so the person can function without causing harm to themselves or others. What does that management look like psychologically?
Well, the undisputed cornerstone is cognitive behavioral therapy, CBT. It's very practical. Key parts include rigorous relapse prevention planning, teaching people to spot their high-risk situations, their personal warning signs, and have plans to deal with urges safely. And, like we discussed, for those whose paraphilias carry a risk of harm, challenging those cognitive distortions and trying to build genuine empathy for victims is absolutely crucial.
Are other psychological approaches used alongside CBT?
Oh, yes. Depending on the individual, other things can help. For someone whose issues seem rooted in early attachment problems or deep-seated conflicts, psychodynamic therapy might offer valuable insights. And for those really struggling with isolation, social skills training can be vital. Building confidence to form healthy, normative relationships can reduce the reliance on that solitary fantasy world.
Okay, now let's shift to the pharmacological side. The medications used to, I guess, turn down the intensity of the drive behind the behavior. The first-line treatment is apparently often a common type of drug, which might surprise some people.
That's right. It's often the SSRIs, like fluoxetine. We mainly know them as antidepressants. But they're used here because a common side effect is reducing overall libido. Perhaps more importantly, they can also lessen the intensity of obsessive or compulsive sexual thoughts. They kind of help quiet the mental chatter, making the urges feel less overwhelming and easier to resist.
But for more severe, high-risk situations, the sources talk about needing much stronger tools, hormonal agents.
Absolutely. For individuals who haven't responded to other treatments or who pose a significant risk, the main agents are anti-androgens, something like medroxyprogesterone acetate, or MPA. These work by significantly lowering or blocking testosterone. The effect is a drastic reduction in sexual drive and the frequency or intensity of fantasies. Clinically, they're used as a powerful tool to manage risk.
And then there's the more modern approach, using GnRH agonists. Why are these considered, well, better or more sophisticated than the older anti-androgens?
The mechanism is quite interesting. Older antiandrogens mostly just block testosterone receptors or interfere with the hormone already floating around. GnRH agonists, like leuprolide, are more effective because they essentially trick the pituitary gland, the body's hormone control center, into shutting down the production signal for testosterone right at the source. It leads to a much more profound suppression of the primary driver of sexual urge. Importantly, this effect is temporary, medically supervised, and reversible. It offers the most significant reduction in paraphilic urges for very severe treatment-resistant cases. So if you pull all these threads together, from potential frontal lobe differences right through to the impact of GnRH agonists, the picture that emerges is one of real complexity. The clinical community has definitely moved towards a more sophisticated understanding, one that carefully separates the desire from the actual pathological consequences. The focus now is very pragmatic: management, control, and protecting potential victims.
So what does all this mean for you as you try to make sense of human behavior? I think it means that when looking at these really challenging areas, the diagnosis of pathology, of disorder, it really hinges entirely on the functional consequences. Is there significant distress? Is there major impairment in life? Is there harm or risk of harm to others? It's not just about having an atypical interest. It's a powerful reminder of how clinical definitions have to balance science with, frankly, profound ethical responsibility.
Absolutely. And that leads us perfectly into our final thought for you to consider. Given that research clearly points to some neurobiological vulnerabilities, maybe in impulse control pathways or brain structure differences, how might future research shift things? Could really understanding, maybe even finding ways to mitigate these early developmental vulnerabilities, perhaps before they get cemented by conditioning or defensive cognitive distortions, offer hope? Could we potentially move towards preventing the development of the most severe, harmful paraphilic disorders, rather than focusing mainly on managing the behavior once it's established? That, I think, is the ultimate frontier and perhaps the greatest hope in this challenging field.